Usually when we talk about joint replacement or orthopedic surgery in general, there is this underlying expectation of restoration.
Right. Yeah.
Like, it's treated almost like mechanical engineering. You replace a hip or a knee, and the patient goes back to hiking or golfing,
Yeah.
essentially, living their life without limits.
Exactly. I mean, we view it as a clean, predictable mechanical swap.
Right.
There's an expectation from both the surgeon and the patient of a return to full, unrestricted function. A new joint equals a new lease on an active life.
But then you step into the world of the elbow, and suddenly that expectation just shatters completely.
Oh, complete.
We are looking at a biomechanical landscape that is, well, it's incredibly unforgiving. The anatomical real estate is packed with danger, and our absolute best surgical fixes come with severe lifelong compromises. It really forces you to reevaluate what a successful surgery actually looks like.
Yeah, it is the absolute definition of an unforgiving joint. I mean, with a hip, you have a massive ball deeply seated in a socket. It's inherently stable. But the elbow is a dizzyingly complex trochlear joint balancing flexion, extension, and forearm rotation all at once, and it's surrounded by barely any soft tissue coverage.
Right.
The margins for error are just microscopic.
Which brings us to the purpose of today's deep dive.
Mm-hmm.
So welcome to this custom-tailored audio-only study session.
Glad to be here.
Whether you are driving down the motorway right now or you've got your headphones in while doing the dishes, we know you are multitasking. You are prepping for the FRCS Trauma and Orthopaedics exam, and, your time is precious.
Extremely precious.
So because you can't take notes right now, we have designed this specifically for the distracted listener. There are zero visual references here, none. You don't need to look at a screen. You don't need to imagine a complex diagram.
And crucially, because we know you are listening while on the move, we are going to state every single vital exam fact and discriminator exactly twice.
Yes.
We're going to organically build in the repetition for you so the knowledge sticks in your working memory by the time you reach your destination.
Perfect. So today's mission is mastering elbow pathology and arthroplasty. And to do that, we need a mental framework to hang all this information on.
Right. So the spine of this entire deep dive is a simple structure you can hold in your mind without writing anything down.
Okay.
All elbow pathology we are covering today falls neatly into 3 buckets, and throughout all of it, you are stalked by 2 nerves.
3 buckets, 2 nerves. Okay. Lay out the buckets for us.
Bucket number 1 is the overuse tendinopathies.
Right.
Bucket number 2 is the developmental lesions, and bucket number 3 is the reconstructive endgame.
Got it. And the nerves.
Those 2 nerves hovering over every single surgical decision you make. Well, laterally, on the outside of the elbow, it is the posterior interosseous nerve, the PEN.
PEN, okay.
Medially on the inside, it is the ulnar nerve. Whatever you do around the elbow, one of those 2 is lurking in the shadows waiting to be injured.
PN on the lateral side, ulnar on the medial side.
Yeah.
Okay, let's unpack this. Beginning with that first bucket, the overuse tendinopathy.
Yeah.
And really, if we are looking at sheer volume in an orthopedic clinic and high-yield questions on the exam, we are zeroing in on lateral epicondylitis, tennis elbow.
Yes, tennis elbow. And right out of the gate, we need to address the most dangerous trap surrounding this condition, which is the name itself.
Oh, absolutely.
The term epicondylitis is a complete lie. It leads you down the wrong pathophysiological pathway.
I have always hated the detronic suffix for this condition.
I know, right?
In medicine, detronitis implies an active, acute inflammatory cascade. Appendicitis, tonsillitis, dermatitis. It brings to mind this fiery cellular response, vasodilation, white blood cells rushing to the site, prostaglandins, macrophages cleaning up debris.
Exactly.
If I hear alondylitis, I think of an active biological fire. But that is fundamentally not what is happening in a tennis elbow tendon, is it?
It is fundamentally not happening. If we take a biopsy of a tennis elbow tendon and look at it under a microscope, we do not see an inflammatory fire.
Yep.
What we see is a failed healing response. The specific term the examiners want you to know, the pathology coined by Robert Nerschel back in the 1970s, is angiofibroblastic tendinosis.
Okay, I want to make sure I have the exact exam phrasing locked in. The strict pathological diagnosis is angiofibroblastic tendinosis.
Exactly. The strict pathological diagnosis for tennis elbow is angiofibroblastic tendinosis.
So break down that jargon for me. What exactly am I looking at under that microscope if it isn't inflammation?
You are looking at a tissue that has tried to heal itself and just given up. Angio refers to blood vessels, fibroblastic refers to the cells that build tendon tissue, and tendinosis means chronic degeneration.
Right.
When you look at the histology, you see highly disorganized collagen. Instead of thick parallel bundles of type I collagen, you have a messy, weak matrix.
Okay.
You see immature, dysfunctional fibroblasts that aren't doing their job, and you see neovascularization.
Which is what?
These tiny, chaotic, abnormal new blood vessels trying to push into the area to bring nutrients, but they fail to form a functional network.
It sounds like a construction site where the workers are exhausted, the scaffolding is falling apart, and they're just throwing random materials at the wall hoping it holds.
That's a great way to put it.
And what is conspicuously missing from this construction site?
Inflammatory cells. You see absolutely zero inflammatory cells. There are no macrophages, no neutrophils swarming the area. It is just a degenerative soup.
Let's cement that histology for the listener driving right now. Tennis elbow is a failed healing response called angiofibroblastic tendinosis, which features disorganized collagen, immature fibroblasts, neovascularization, and absolutely zero inflammatory cells.
Yes. Stating that vital pathology one more time. Tennis elbow is a failed healing response called angiofibroblastic tendinosis, featuring disorganized collagen, immature fibroblasts, neovascularization, and absolutely zero inflammatory cells.
So we know the exact what of the pathology, but let's talk about the where. The lateral epicondyle is a massive bony prominence, and it acts as the origin point for a whole wad of extensor muscles that travel down the forearm. Which specific tendon in that group is the one actually degenerating?
The primary culprit, the epicenter of this angiofibroblastic tendinosis, is the origin of the extensor carpi radialis brevis, the ECRB.
The ECRB. Now, why the ECRB specifically? Why not the longus or the extensor digitorum? Is there a mechanical reason this specific tendon takes the brunt of the damage?
It is entirely mechanical. The ECRB sits uniquely close to the radiocapitellar joint.
Right.
As you repeatedly pronate and supinate your forearm, turning your palm up and down the ECRB, tendon actually glides and rubs directly against the lateral edge of the capitellum and the radial head.
Ah, I see.
This creates a constant microscopic friction shear force. Over years, that friction, combined with the tension of gripping, creates micro tears in the tendon origin that the body simply fails to repair.
That makes total sense. It's a mechanical fraying over a bony edge. And understanding that anatomical attachment that the ECRB runs down the forearm and attaches specifically to the base of the third metacarpal, the middle finger, that dictates exactly how we isolate it during a clinical exam.
Exactly. To test for tennis elbow on an exam, you ask the patient to keep their elbow completely straight, and then you have them resist middle finger extension.
Let's visualize that for a second. If the elbow is bent, you introduce slack to the system.
Right.
But by keeping the elbow locked perfectly straight, you pull the ECRB tendon as taut as a guitar string. Then, because it attaches to the base of that third metacarpal, forcing the patient to extend just their middle finger against your resistance, fires the ECRB independently of the other wrist extensors.
Spot on.
If that tension reproduces their sharp pain right at the lateral epicondyle, you found your angiofibroblastic tendinosis.
Yes. Now, understanding that this is a chronic, degenerative, failed healing response and not an acute inflammation should completely dictate our treatment philosophy.
Which explains why the treatment is overwhelmingly conservative.
Yeah.
You cannot cut out a failing biological response and expect it to magically heal. You have to coax it back into a healthy remodeling phase.
Exactly. We're talking about activity modification, an eccentric loading physiotherapy program, and perhaps a counterforce brace.
The brace, right?
The counterforce brace is interesting. It's a tight band worn a few centimeters below the elbow. It works by compressing the muscle belly, effectively creating a new artificial origin point for the muscle, which unloads the diseased ECRB tendon at the epicondyle.
Oh, that's clever.
Yeah. The reality is that this condition is largely self-limiting, but it requires massive patience from the patient, often 12 to 18 months to fully resolve.
But here is the real-world pushback you get in clinic. A patient comes in, they are in agony, they can't pour a kettle or hold a tennis racket, they want a quick fix.
Oh.
And historically, the reflex action for a lot of clinicians was to just draw up a syringe of corticosteroid and jab it straight into the lateral epicondyle. Steroids are the ultimate anti-inflammatory weapon, but we just spent the last 10 minutes establishing that there is no inflammation here. So what are we actually doing with that needle?
That is the critical exam point, and it's why corticosteroids are rapidly falling out of favor in the literature.
Okay.
If you inject a steroid into an angiofibroblastic tendinosis, you will give your patient magical, profound, short-term relief. They will feel fantastic for about 4 to 6 weeks.
Right.
But the data shows clearly that steroid injections lead to worse long-term outcomes at 1 year compared to doing nothing at all.
Why? What is the biological mechanism of that failure? If there's no inflammation to suppress, why does the steroid make it worse long-term?
Because corticosteroids are catabolic. They break down tissue. They inhibit fibroblast activity and decrease collagen synthesis. Remember, the ECRB is already suffering from disorganized collagen and immature fibroblasts. By injecting steroids, you are chemically shutting down whatever feeble healing response the body was trying to mount. You mask the pain perfectly, but you structurally weaken an already degenerating tendon.
So you are basically silencing the fire alarm while chemically weakening the structural beams of the house. That is a dangerous combination.
Very dangerous.
So we aggressively avoid the needle. What about the knife? When do we actually consider operating on a tennis elbow?
Surgery is strictly a salvage procedure for a tiny minority of patients. It involves an open or arthroscopic debridement where you literally cut out the diseased, gray, friable ECRB tissue down to bleeding healthy bone, hoping to stimulate a fresh, acute healing response.
Okay.
But it is reserved only for patients who remain severely disabled after a minimum of 6 to 12 months of dedicated, high-quality conservative management.
Okay, so that is the classic textbook presentation of lateral epicondylitis. But the FRCS examiners are rarely that straightforward. They love a mimic.
They really do.
They love giving you a clinical vignette of a patient who looks exactly like they have tennis elbow, but it's an anatomical trap. And this brings us back to our overarching framework, specifically the first of our two nerves.
Yes. The mimic you must constantly have on your radar is radial tunnel syndrome. This is a compression neuropathy of the posterior interosseous nerve, the P.
The P.
Yeah.
That lateral nerve danger lurking in the shadows.
Exactly. The P is a motor branch of the radial nerve. As it travels down the arm, it dives deep into the forearm muscles and passes through the radial tunnel, specifically diving under a fibrous arch in the supinator muscle called the arcade of Fros.
Right.
If it gets compressed there, it mimics tennis elbow beautifully because it causes deep, aching lateral elbow pain.
So if I am reading an exam stem or examining a patient, how do I physically distinguish the degenerative tendon from the compressed nerve? Where is the exact discriminator?
The discriminator is the precise anatomical location of the maximum tenderness. In tennis elbow, the pinpoint pain is exactly on the bony bump, the lateral epicondyle itself. In radial tunnel syndrome, the maximum tenderness is more distal. It is about 3 to 4 centimeters further down the forearm, deep in the mobile wad of muscle where the nerve is actually diving into the supinator.
That spatial relationship is vital. Let's make sure the listener has that locked in. Tennis elbow tenderness is exactly on the lateral epicondyle. Radial tunnel syndrome, which is PIN compression, is tender 3 to 4 centimeters distal to the epicondyle, in the muscle belly.
Yes. Furthermore, with radial tunnel syndrome, you won't typically see those classic epicondyle findings on the resisted middle finger expansion test. It is a deep radiating nerve ache, not a tendon tension pain.
Got it. And just to close the loop on this section, what about the medial side of the elbow, golfer's elbow? Does the pathology change?
Not at all. Golfer's elbow is the exact same underlying pathology. It is an angiofibroblastic tendinosis. The only difference is geography. It affects the flexor pronator muscle origin on the medial epicondyle instead of the extensors on the lateral side.
Brilliant. All right, to wrap up bucket number 1, we have a strict rule for this study session. At the end of every topic, we distill it down. If you only keep one thing from this segment, what is it? I will state the rule, and then I will state it again.
Let's hear it.
If you only keep one thing, tennis elbow is an ECRB, angiofibroblastic tendinosis, not inflammation treated conservatively, and can be mimicked by PIN compression in the radial tunnel. Repeating that to cement it. Tennis elbow is an ECRB, angiofibroblastic tendinosis, not inflammation treated conservatively, and can be mimicked by PIN compression in the radial tunnel.
Perfect transition. That firmly closes bucket number 1, the adult overuse tendinopathies. We are now moving into bucket number 2, the developmental lesions. We are shifting our focus from the degenerative failures of adulthood to the complex biological processes of the growing skeleton.
Right. And when we talk about the growing elbow, we have to talk about how cartilage matures into bone. And the classic showdown in this developmental bucket, the two conditions that exam writers absolutely love to pit against each other, are osteochondritis dissecans of the capitellum, commonly known as OCD, versus its younger cousin, Panner's disease.
Oh, yeah. These two conditions are fascinating because they affect the exact same anatomical real estate.
Right.
They both target the capitellum, which is that round, ball-like articular surface on the lateral side of the distal humerus that articulates with the concave radial head. But despite hitting the same spot, they behave completely differently because of the host's biology.
So if I'm listening to this in the car right now and a question starts describing a kid with lateral elbow pain,
Yeah.
how do I instantly separate them? What is the discriminator that divides Panners from OCD?
It is entirely about the age of the patient, which dictates the prognosis. I will say this clearly. Age and prognosis are the strict discriminators between Panners and OCD.
Wait, literally just age. If I see a 7-year-old and a 14-year-old with the exact same vague lateral elbow pain, the 7-year-old has Panners and the 14-year-old has OCD.
Yes. Age and prognosis are the strict discriminators between Panners and OCD. The age tells you the state of the cartilage, and the state of the cartilage tells you the prognosis.
Okay, let's explore the biological why behind that age gap, starting with the younger child. Panners disease.
Right. Panners disease almost exclusively strikes young children, classically between 5 and 10 years old. Pathology-wise, it is an osteochondrosis of the entire capitellar ossific nucleus.
An osteochondrosis.
Right.
Let's break that underlying mechanism down for the listener. This basically means there's a temporary disruption of blood supply to that developing bone center. It's avascular necrosis. The blood flow stops, and the immature bone inside the capitellum begins to fragment and die.
Correct. But what's fascinating here is how the extreme immaturity of the child's skeleton acts as a protective shield.
How so?
Well, in a 7-year-old, the capitellum is mostly cartilage. The actual bony nucleus inside is quite small, and it is surrounded by an incredibly thick, robust, pliable envelope of unossified cartilage.
So even though the bone on the inside is temporarily crumbling from a lack of blood flow, that thick outer cartilage layer is so strong, it holds the entire anatomical shape together.
Exactly.
It's like having a crushed piece of hard candy sitting perfectly contained inside an intact, thick plastic wrapper. The internal structure is failing, but the external shape holds flawlessly.
That is an excellent analogy. Because that thick cartilage wrapper holds the joint surface perfectly smooth, the joint mechanics remain normal. The crushed bone inside is given the time and stable environment to eventually revascularize, remodel, and heal completely.
Oh, wow.
Therefore, the prognosis is excellent. Cannell's disease is entirely self-limiting. It resolves with simple rest and activity modification. It leaves no loose bodies, no residual deformity, and no early arthritis.
So, to summarize the young end of the spectrum, under 10 years old, it's Panners disease. It involves the entire capitellar nucleus. The thick cartilage holds it together, and it is totally benign and self-limiting. But what happens when that 7-year-old grows up and becomes a 14-year-old teenager?
That is when we enter the dangerous territory of osteochondritis dissecans, or OCD, of the capitellum. This strikes adolescents, strictly between 11 and 15 years old.
Okay.
And the classic exam vignette won't just give you their age, it will give you their hobby.
Right.
It is always a young, elite throwing athlete, like a baseball pitcher or a high-level gymnast who walks on their hands.
Because the mechanism of injury has completely changed. Panners was a random vascular event. OCD is a brutal mechanical event. Let's explain the biomechanics of a baseball pitch, because that explains exactly how this lesion forms.
Right. In the late cocking and early acceleration phase of pitching a baseball, the biomechanics create an enormous valgus stress on the elbow. Valgus meaning the forearm is being forced aggressively outward, away from the body.
Let's visualize that valgus stress in 3D. When the forearm is forced outward, the inside of the elbow, the medial side, is violently stretched, placing massive tension on the ulnar collateral ligament. But at the exact same moment, the outside of the elbow, the lateral side, is being violently compressed.
Precisely. That valgus force translates into repetitive, severe compression and shear forces right at the radiocapitellar joint. The radial head acts like a hammer, smashing against the capitellum over and over again with incredible force.
And here is the crucial biological difference. Because this is a 14-year-old, their cartilage is totally different from the 7-year-olds.
Yes. In the adolescent, the capitellum is now almost fully ossified into bone. That thick, protective plastic wrapper of cartilage we talked about in Panners, it has thinned out dramatically into a normal, thin layer of articular cartilage. It can no longer absorb massive shock.
So when the radial head repeatedly smashes into it, something has to give.
And what gives is the subchondral bone. This repetitive radiocapitellar shear causes a focal microvascular trauma. It creates a localized pothole of dead bone and overlying cartilage, specifically located on the anterolateral aspect of the capitellum.
Anterolateral.
Notice the difference. Panners involve the entire nucleus. OCD is a focal, specific anterolateral lesion caused by mechanical impact.
And because that cartilage wrapper is so thin now, that pothole is structurally compromised. The wrapper can actually tear.
That is the crux of the prognosis. Unlike Panner's, an OCD lesion can become unstable. If the repetitive trauma continues, that piece of dead bone and its overlying articular cartilage can physically detach, fall out of the pothole, and float away into the joint space as a loose body.
Oh, wow. This fundamentally changes our management algorithm. If Panner's just needs a few months of rest, what does the adolescent with OCD need?
Management entirely depends on one question: is the lesion stable or unstable? If you catch an adolescent pitcher early and their MRI shows a stable lesion, meaning there is edema in the bone, but the cartilage wrapper on top is perfectly intact with no fluid undermining it, you can attempt conservative management. Complete cessation of throwing for up to 6 months. Sometimes, if the biological environment is quieted down, it will heal.
But if they come into your clinic complaining that their elbow is physically locking up or clicking or catching, and you get an MRI that shows a moat of high-signal fluid surrounding the fragment or a loose piece of bone wandering around the joint space,
Then conservative management is over. You are headed to surgery. An unstable lesion or a detached loose body mandates elbow arthroscopy. If the fragment is already loose and floating, you usually have to remove it and then debride the empty crater, often performing a microfracture, punching tiny holes in the bone bed to stimulate marrow bleeding and fibrocartilage formation. Very rarely, if the fragment is huge and perfectly intact, you might attempt to fixate it with a bioabsorbable screw, but removal and debridement is far more common.
All right, let's crystallize this crucial developmental showdown. The discriminator is age. Let's apply a rule. If you only keep one thing, Panner's is the young child's self-limiting capitellar osteochondrosis. OCD is the adolescent thrower's focal anterolateral capitellar lesion that can fragment. Let me state that twice so you don't forget it. Panner's is the young child's self-limiting capitellar osteochondrosis. OCD is the adolescent thrower's focal anterolateral capitellar lesion that can fragment.
Excellent. Staying firmly in bucket number 2 are developmental lesions. We are going to move away from the growing child and look even further back to birth anomalies. The FRCS exam expects you to master 2 specific congenital elbow problems. The first is congenital radial synostosis.
Let's decode the terminology. Synostosis. Syn meaning together, osteon meaning bone. The radius and the ulna, the 2 long bones of the forearm, are physically fused together. How does that happen biologically?
It is a failure of embryological development. Between the 4th and 8th week of gestation, the bones of the upper limb start as a single, continuous, cartilaginous mesenchymal block.
Okay.
As development progresses, that block is supposed to separate longitudinally into 2 distinct bones. In radial synostosis, that longitudinal cleavage fails proximally, leaving a solid bony bridge fusing the proximal radius to the proximal ulna.
And the mechanical implication of that is severe. If the radius and ulna are welded together into a single block of bone, forearm rotation is physically impossible. You cannot pronate and you cannot supinate.
And here's the classic exam trap they will set for you. They will ask you how the forearm is positioned at rest. It is almost always fixed in severe pronation.
Let's make sure that's bolded in the listener's mind.
I will state it twice. In congenital radial synostosis, the forearm is fixed in pronation. Again, in congenital radial synostosis, the forearm is fixed in pronation.
Meaning the palm is permanently facing down toward the floor. Now, intuitively, if I am a junior orthopedic trainee, I might think, well, the problem is a bony bridge. I am a surgeon. I own a saw. Surely the treatment is to just go in, surgically cut the bony bridge, separate the radius and ulna, and magically give the child their rotation back.
And that perfectly logical thought is exactly what the examiners are waiting for you to say so they can fail you. You must aggressively resist that temptation.
Wait, really? Why? Why can't we just separate the bones? What happens if we try?
Because it inevitably, catastrophically fails. You have to remember the embryology we just discussed. The entire forearm developed under the assumption that those bones were one single unit.
Ooh.
That means the interosseous membrane, the surrounding periosteum, the fascial compartments, the muscles, everything is structurally adapted to a fused state. If you go in with a saw and cut the bony bridge, you incite massive surgical trauma to a highly reactive periosteum. The child's stem cells go into overdrive, resulting in massive heterotopic ossification.
Heterotopic ossification, meaning the body aggressively builds new abnormal bone in the soft tissues to heal the fracture you just created.
Exactly. The body bridges the gap with thick, disorganized new bone, and the synostosis simply reforms, often worse than before. So the rule is absolute. Attempts to surgically separate the bones inevitably fail and reform.
I will repeat that critical testable fact. Attempts to surgically separate the bones inevitably fail and reform. So what is the treatment algorithm? Do we just leave a child with hands permanently stuck facing the floor?
In many cases, yes. It is often a bilateral condition, sometimes associated with syndromic issues like Apernert syndrome or Klinefelter's. Children are incredibly adaptable neuroplastically. They naturally compensate for the lack of forearm rotation by using hypermobile shoulder abduction and wrist flexion to position their hands.
Oh, that makes sense.
They adapt beautifully. We only ever consider operating if the fixed pronation is so severe that it is highly disabling, for instance. If the angle is so bad, they literally cannot get a fork to their mouth or wash their face.
But if separation fails, what is the surgery?
The surgery is a rotational osteotomy. You do not try to restore motion. Instead, you accept the fusion, you move further down the forearm away from the synostosis, you cut completely through both the radius and ulna, physically rotate the entire distal forearm block into a more functional, static position, like neutral or slight supination, and fix it there with plates or wires. You don't give them a moving joint, you just permanently change the angle of the fusion to a better resting position.
That is a phenomenal explanation of the why behind the exam fact. Never try to separate a synostosis because of heterotopic ossification. Only do a rotational osteotomy for severe disability. Okay, what is the second congenital anomaly we need to master?
Congenital radial head dislocation. It might surprise you, but this is actually the most common congenital anomaly of the elbow.
Now, pediatric radial head dislocations happen constantly in trauma. The classic nursemaid's elbow where a toddler is pulled by the arm, or a complex Montagia fracture dislocation where the ulna breaks and the radial head pops out. So if you are looking at an x-ray of a 6-year-old with a dislocated radial head, how do you know if it's congenital or traumatic? What is the visual tell for the audio listener?
The discriminator is entirely about the morphological shape of the radial head on the x-ray. I'm going to describe this carefully. A normal radial head, or one that was traumatically dislocated recently, is concave. It has a little hollowed-out dish on top that perfectly cups the round capitellum.
Right, it looks like a golf tee holding a golf ball. The radial head is the tee, the capitellum is the ball.
Exactly. But in a congenital dislocation, the radial head popped out of joint in utero. It never developed against the capitellum. It never had that round, bony mold to press against to form its shape. So instead of developing a concave dish, it grows outward into a dome. It becomes dome-shaped, convex, and hypoplastic, meaning abnormally small and underdeveloped.
It's the concept of a developmental mold. If the clay is never pressed into the mold, it doesn't form the shape. So the discriminator is the convex shape. I'm going to say this twice for the listener. To distinguish congenital from traumatic, look at the radial head. Congenitally, it is dome-shaped and convex. Repeating that visual tell congenitally, the radial head is dome-shaped and convex.
That is the primary discriminator. Secondarily, it is almost always dislocated posteriorly. It is typically totally painless with just a mild limitation in rotation, and it is very often bilateral. So if the exam stem gives you a painless bilateral posterior dislocation with a domed head, you confidently select congenital radial head dislocation.
Perfect. Let's apply our rule for these two congenital anomalies to close out bucket number 2. If you only keep one thing, radial sign or synostosis fixes the forearm and pronation and separation surgery fails. Congenital radial head dislocation shows a dome-shaped convex radial head. Twice for the road radial and a synostosis fixes the forearm and pronation and separation surgery fails. Congenital radial head dislocation shows a dome-shaped convex radial head. Okay, it is time for our first pick stop. Mid-episode recap 1. We are going to do a rapid, rigorous review to cement these facts before we move on.
Let's lock it in.
Bucket 1, the overuse. Tennis elbow is an ECRB angiofibroblastic tendinosis. It is not an inflammation. You treat it conservatively. And its main mimic is radial tunnel syndrome, which is PIN compression found further down the muscle belly.
Bucket 2, developmental. OCD versus Panners. Age is your strict discriminator. Panners is the young child's benign, self-limiting osteochondrosis protected by thick cartilage. OCD is the adolescent thrower's focal lesion that can fragment due to valgus shear stress.
And finally, the congenital anomalies. Radial narnar synostosis fixes the forearm and pronation, and you never try to separate the bones because it fails through heterotopic ossification. Congenital radial head dislocation is identified by a domed, convex radial head. All right, take a deep breath. We have covered the overuse and the developmental buckets. Now we enter bucket 3, the reconstructive endgame. How do we surgically fix these complex lesions?
And this is where we return powerfully to our overarching theme, the two nerves, because whenever we enter the elbow surgically, we are navigating a terrifying anatomical minefield.
Here's where it gets really interesting, because navigating the elbow joint blindly with an arthroscope is incredibly daunting if you don't fully respect the anatomy. It's not a knee. You don't have massive forgiving spaces. It's a tiny, tight capsule surrounded on literally all four sides by major, life-altering neurovascular structures.
It is entirely different from a knee. In the elbow, the major nerves, the median, radial, ulnar, and the PA are lying right on top of the thin joint capsule. So there are two non-negotiable safety principles, two exact mechanical first steps you must take before you ever insert a blade or a sharp trocar to make your first portal.
Let's get these burned into the listener's memory. What is step one?
Step one, you must distend the joint with fluid before making a portal. You insert a blunt needle into the soft spot and inject 20 to 30 milliliters of sterile saline.
Okay, I understand injecting fluid to see, but why is it a safety principle? What is the mechanical benefit of doing that before making the portal?
Think of the elbow joint capsule like a deflated balloon resting inside a cramped, rigid box with all the major nerves resting directly on the outer skin of that balloon.
Okay.
If you stick a knife in while it's deflated, the capsule is sitting right against the nerves. You will slice a nerve. But if you fill that balloon with 30 cc's of water, it expands forcefully outward. As the capsule balloons, it physically pushes the overlying neurovascular structures away from the bone and away from your intended portal sites. It artificially creates a safe, fluid-filled buffer zone.
Distend to inflate the balloon and push the nerves away. I love that visual. So that gives us a buffer. But what is step two? Because pushing them away might not be enough.
Step two, you must keep the elbow flexed to approximately 90 degrees during portal placement.
Again, let's explain the anatomical why for the listener. If I just distend the joint, the nerves are pushed away, but the anterior nerves, the median nerve, and the brachial artery still feel dangerously close to the front of the capsule. Is flexing the elbow to 90 degrees a physical way to introduce slack to those specific structures?
Precisely. It is all about the brachialis muscle. The anterior neurovascular bundle runs down the arm lying on top of the brachialis muscle, which sits right over the anterior capsule.
Okay.
If you extend the elbow perfectly straight, you pull the brachialis tight, which bowstrings the median nerve and brachial artery hard against the front of the joint, right in the path of your instruments.
It pulls them taut like a tripwire.
Yes, but when you flex the elbow to 90 degrees, the brachialis muscle relaxes completely. As it relaxes, it bows forward away from the joint, and it carries that vital anterior neurovascular bundle forward with it, pulling them significantly further away from the anterior joint capsule.
Those are absolute golden rules of safe arthroscopy. Let me state them twice. In elbow arthroscopy, the two non-negotiable safety steps are 1, distend the joint with fluid before making a portal, and 2, keep the elbow flexed to 90 degrees. Repeating that sequence: 1, distend the joint with fluid before making a portal, and 2, keep the elbow flexed to 90 degrees.
So your joint is distended, your elbow is flexed to 90. Now you need to make your first portal to look inside. Most surgeons establish the proximal anteromedial portal first because it gives a fantastic, safe, wide-angle panoramic view of the anterior compartment.
Right.
But every single portal you make around this joint carries a specific testable nerve risk. The examiners will expect you to mentally map 3D anatomy and tell them which nerve is endangered by which specific portal angle.
Let's map it out clearly.
Medial portals like your anteromedial or proximal anteromedial portals threaten the median nerve and the medial antebrachial cutaneous nerve.
Okay.
The anterolateral portal threatens the radial nerve, and our old friend, the posterior interosseous nerve, the PN.
The PN.
And the posterolateral or direct posterior portals threaten the ulnar nerve.
Let's trace that logic. Medial threatens median. Anterolateral threatens radial and PIN because the radial nerve sweeps down the lateral side of the arm and the PN dives into the supinator right there. Posterior threatens the ulnar nerve as it passes behind the medial epicondyle. But there's a major exam trap here regarding overall nerve injury statistics, isn't there?
Yes, a huge trap. Despite all the intense focus and worry about the anterior structures, the median and radial nerves, the most commonly injured nerve overall in all of elbow arthroscopy, is actually the ulnar nerve.
I want to emphasize that loudly. The most commonly injured nerve overall in elbow arthroscopy is the ulnar nerve. Repeating for the record, the most commonly injured nerve overall is the ulnar nerve. Now, Theorize with me here. Why the ulnar, we spend all this time worrying about the anterior structures, distending the joint, flexing to 90. Is it because the ulnar nerve is so superficial at the back of the elbow, sitting right behind the epicondyle, that it's just inherently vulnerable to any stray instrument?
It is partially its superficial, highly vulnerable location in the cubital tunnel, but it is also because of its lack of mobility. It is tethered behind the epicondyle.
Oh, I see.
When you distend the joint with fluid, the capsule expands backward as well, tightening against the ulnar nerve. If your posterolateral portal strays even slightly too medial, you are right on top of it.
Wow.
Furthermore, it is incredibly sensitive to transient neuropraxia, a stretching or concussive stunning of the nerve from fluid extravasation. It's rarely transected, but it gets stunned very easily.
And this highlights why taking a good history is vital. If a patient has had a previous ulnar nerve transposition, where a surgeon previously moved the nerve to the front of the elbow to relieve compression, that completely scrambles your normal portal safety map, right?
Completely. If they've had a transposition, the ulnar nerve is no longer where you expect it to be. It might be scarred right across your planned medial portal sites. That is an absolute red flag.
So to synthesize the arthroscopy rules, if you only keep one thing, in elbow arthroscopy, distend and flex to 90 degrees. First, the ulnar nerve is the most commonly injured, and the anterolateral portal endangers the PN. One more time for safety in elbow arthroscopy, distend and flex to 90 degrees. First, the ulnar nerve is the most commonly injured, and the anterolateral portal endangers the PN.
Which perfectly leads us to the final, most extreme frontier of our reconstructive bucket. What happens when the joint is simply beyond the scope of a camera and a shaver? When the cartilage is utterly obliterated, the bone is actively eroding, and the pain is intolerable.
We look at total elbow arthroplasty, the TEA, total elbow replacement.
Now, if we return to your philosophical opening thought about joint replacements, a hip and a knee are designed to take massive loads and restore normal athletic function. A knee replacement absorbs the impact of walking down stairs.
Right.
The elbow replacement emphatically does not. The history of elbow arthroplasty is littered with catastrophic failures because the biomechanics of the elbow are brutally complex.
Let's delve into that history. Early on, surgeons just thought, well, the elbow is a hinge. Let's just put a rigid metal door hinge in there. Why did that fail so spectacularly?
Because the elbow is not a simple hinge. It is a highly complex trochlear joint. When you flex and extend your arm, the joint doesn't just hinge, it rolls, it slides, and it actually has built-in rotational toggle, a few degrees of natural laxity.
Oh, yeah?
When early engineers put perfectly rigid, locked metal hinges into patients, they ignored that rotational toggle.
And the physics of that are brutal. If the hinge is perfectly rigid, where does all the rotational force from the hand go?
It goes straight into the bone. If you hold a weight in your hand and rotate your wrist, that torque travels up the forearm. If the artificial hinge won't let the joint rotate slightly to absorb it, that massive torque is transmitted directly to the cement bone interface, the glue holding the long metal stems inside the humerus and ulna bones.
Oh, wow.
And the lever arm is huge. The torque would literally rip the implants right out of the bone. It caused massive aseptic loosening and early catastrophic failure.
So the rigid hinge was abandoned. How did the engineering evolve to solve this?
We arrived at two different design families. We have unlinked designs, also known as unconstrained, and link designs, known as semi-constrained.
Let's define those for the audio learner. What is an unlinked, unconstrained elbow?
An unlinked design is basically surface replacement. You put a metal cap on the end of the humerus and a plastic dish on the ulna, but they are not physically connected to each other by any hardware.
Okay.
They rely entirely on the patient's own native soft tissues, the medial and lateral collateral ligaments to keep the joint from dislocating.
But the inherent flaw there is that patients needing an elbow replacement, especially rheumatoid patients or severe trauma patients, often have utterly destroyed ligaments and terrible bone stock. They don't have the soft tissue to hold an unlinked joint together.
Exactly, which is why the linked semi-constrained design is the gold standard, dominates the market, and dominates the exam. A linked design has a physical hinge connecting the humeral stem and the ulnar stem. A pin drops through them, locking them together so they cannot dislocate.
Right.
But, and this is the genius of the design, pioneered by Bernard Mori, it's not a rigid hinge, it is a slopey hinge.
A sloppy hinge. That sounds like an engineering defect, but it's actually the key to survivorship. It's like adding a suspension system to a car to absorb shock.
That's a perfect way to conceptualize it. The hinge has a few degrees of built-in toggle or laxity. The sloppy laxity allows the implant to absorb those rotational stresses from the hand, mimicking the natural micromotion of the elbow, rather than transmitting that shear force to the cement bone interface. Meanwhile, the physical linkage prevents it from dislocating, even if the patient's collateral ligaments are completely gone.
So the linked, semi-constrained, sloppy hinge dominates because it tolerates severe ligament and bone deficiency. Now let's talk about the ideal candidate, because I remember you saying this is absolutely not for the 40-year-old construction worker with post-traumatic arthritis.
The exam wants you to know exactly which patient population has the best survivorship with a total elbow replacement. And the definitive answer is patients with rheumatoid arthritis, low demand, elderly patients.
Let's state that twice. The best survivorship for a total elbow arthroplasty is in patients with rheumatoid arthritis. Repeating the best survivorship for a total elbow arthroplasty is in rheumatoid arthritis.
And conversely, it performs abysmally in young post-traumatic patients.
Why the stark difference? Is it just the activity level?
It is entirely the activity level and the biological demand. A young guy who shattered his elbow in a motorcycle crash has dense, strong bone, but he also expects to go back to lifting heavy boxes, swinging a hammer, playing sports.
Yeah.
He will apply massive loads to that implant, and despite the sloppy hinge, he will destroy a total elbow replacement, loosening it from the bone in a matter of years. The rheumatoid patient has osteopenic weak bone, but they have profoundly low functional demands.
This brings us to the lifelong rule, the sobering conversation. When you sit down to explain post-op life to a patient consenting for a total elbow, what do you tell them?
It is the most critical conversation you have in the entire process. Because of the massive joint reaction forces acting on a relatively small implant stem, think about the physics of holding a weight at the end of a long lever arm. There is a strict, permanent, lifelong load restriction. We tell patients they can lift roughly 1 kilogram repetitively. And their absolute maximum single lift for the rest of their entire life is about 2.5 kilograms. That is roughly 5 pounds.
5 pounds. Forever. That is a bag of sugar.
Forever. You cannot lift a heavy bag of groceries. You cannot pick up a growing grandchild. You cannot push yourself forcefully out of a deep armchair using that arm.
Unbelievable.
If you push out of a chair, you apply multiples of your body weight across the implant. It will loosen, it will fail, and revision elbow surgery is a nightmare of bone loss. This is precisely why it is reserved for low-demand patients like the elderly rheumatoid population, whose goal is simply to regain the ability to feed themselves, brush their hair, and perform basic hygiene without excruciating pain.
It really reframes the whole concept of the surgery. It is a salvage procedure for the activities of daily living. Given how delicate it is, let's talk about the complication profile and the surgical approaches, because the FRCS loves this. The complication rate for a total elbow is significantly higher than a hip or knee replacement.
Much higher. It is fraught with danger. You worry about aseptic loosening. You worry greatly about infection because there is barely a few millimeters of skin and subcutaneous fat covering the metal implants at the back of the elbow.
Right.
You worry about polyethylene bushing wear. But the two signature soft tissue worries, the specific complications the exam will probe you on, are triceps insufficiency and ulnar neuritis.
I'll state that twice. The signature complications of a TEA are triceps insufficiency and ulnar neuritis. Once more, the signature complications are triceps insufficiency and ulnar neuritis. Let's dissect the why behind triceps insufficiency. Why is the triceps so uniquely at risk?
Because of the surgical approach. The elbow joint is buried beneath the massive triceps tendon, which inserts broadly onto the olecranon, the tip of the ulna. To get the remurs and the long metal implants down into the humerus and ulna canals, you have to get the triceps out of your way. Historically, you had to surgically detach the triceps from the bone to see what you were doing. And anytime you detach a major, powerful tendon and sew it back, there is a significant risk it won't heal properly, leaving the patient with an extensor leg unable to extend their arm against gravity.
Which explains why surgical approaches have evolved to try and protect it.
You're right. We have named approaches you need to recognize. The Brian Morey approach is a classic triceps reflecting technique, peeling it off medial to lateral. There is a triceps splitting approach, going right down the middle of the muscle belly.
Got it.
And more recently, the Alonzo Lames approach, which is triceps sparing. It navigates on either side of the triceps to preserve the extensor mechanism entirely, though it gives a much more restricted view.
Now, in trauma surgery, like fixing a shattered distal humerus, humerus surgeons often do an olecranon osteotomy. They literally take a saw, cut the tip off the ulna bone with the triceps still attached, flip it up to see the joint, fix the humerus, and then put screws back into the olecranon to fix it. Is there an absolute rule about doing that in elbow arthroplasty?
Yes, the rule is never do it. You must avoid an olecranon osteotomy in arthroplasty. You need that entire proximal ulna bone perfectly intact to hold the stem of the ulnar component of the artificial joint. If you cut it off, you have nowhere to anchor your implant.
And the second signature complication you mentioned was ulnar neuritis.
Which loops right back to our two nerves theme. The ulnar nerve sits right in the surgical field on the medial side. You have to dissect it out of the cubital tunnel, protect it with a tape, and very often formally transpose it, move it permanently to the front of the elbow so it doesn't get stretched, irritated, or scarred down by the bulky new metal joint.
Right.
Handling the nerve inevitably causes transient neuritis in a large percentage of patients.
All right, that is a tremendous amount of high-yield information. Let's summarize this massive reconstructive section. If you only keep one thing, the semi-constrained linked total elbow does best in rheumatoid arthritis, carries a lifelong 5-pound load restriction, and its signature complications are triceps insufficiency and ulnar neuritis. Repeating that vital summary, the semi-constrained linked total elbow does best in rheumatoid arthritis, carries a lifelong 5-pound load restriction, and its signature complications are triceps insufficiency and ulnar neuritis. Which brings us to our second pit stop, mid-episode recap 2. Let's lock in those surgical rules before the final synthesis.
Arthroscopy first. Always distend the joint with fluid and flex the elbow to 90 degrees before making any portals to protect the nerves. The ulnar nerve is the most commonly injured overall, and the anterolateral portal specifically endangers the PS.
And total elbow arthroplasty. The dominant design is the semi-constrained linked sloppy hinge because it tolerates ligament loss. It has the best survivorship in rheumatoid arthritis patients. It carries a strict lifelong 5-pound load limit to prevent loosening. And your two big soft tissue complications to watch out for are triceps insufficiency from the approach and ulnar neuritis. All right, we are entering the final stretch. Bucket number 6 on our outline is the synthesis, the rheumatoid elbow spectrum. And I want to bring this up because there is a direct, seemingly contradictory conflict in a lot of the study materials and question banks out there.
It is a classic discrepancy that confuses a lot of candidates, but it makes perfect sense once you understand the pathophysiology of the disease.
Let me set up the paradox. One quiz question will describe a patient with a rheumatoid elbow, and the correct textbook answer is a synovectomy. Another quiz question will describe a patient with a rheumatoid elbow, and the correct answer is a semi-constrained total elbow arthroplasty. How can both be right? How do you know which one the examiners want?
If we connect this to the bigger biological picture, we realize that both quizzes are right, but they are asking about completely different stages of a progressive disease. Rheumatoid arthritis is a spectrum of destruction. The discriminator that resolves this conflict, the absolute key phrase you are looking for in the exam text, is the radiographic joint surface.
I'm going to state this twice because it resolves the paradox. The discriminator between synovectomy and arthroplasty is the radiographic joint surface. Again, the discriminator is the radiographic joint surface.
Let's break down the two ends of that spectrum. Rheumatoid arthritis is an autoimmune disease where the body's immune system aggressively attacks the synovial lining of the joint.
Let's use a causal metaphor here. Imagine the synovial lining as a factory that is supposed to produce healthy, lubricating joint fluid. In rheumatoid arthritis, that factory goes completely rogue. Instead of lubricant, it starts mass-producing highly toxic inflammatory acid, the pannus. This pannus actively eats away at the cartilage and bone.
That is exactly what happens. In early rheumatoid disease, the factory is in overdrive. The patient has painful, boggy synovitis. The elbow is swollen, hot, and agonizing to move. But if you look at their X-ray, the cartilage space is still visible. The bony joint surface is preserved.
The rogue factory is pumping out toxic acid, but the structural walls of the factory, the cartilage and bone, haven't dissolved yet. They are still standing.
Precisely. In that specific scenario, early disease with a preserved joint surface on X-ray, the correct treatment answer is a synovectomy. You go in, usually arthroscopically, and you physically strip out and excise all that inflamed, diseased synovial tissue. You might also excise the radial head if it's badly affected and blocking rotation.
And the goal there is to tear down the rogue machinery. You remove the source of the toxic pannus, you relieve the patient's pain, and crucially, you actually halt or slow the structural damage while the cartilage is still present to be saved.
Exactly. You are preserving native anatomy. But contrast that with end-stage disease. Imagine a patient who has had uncontrolled rheumatoid arthritis for 20 years. The toxic factory has been running unchecked for decades.
Yeah.
You look at their x-ray and the joint is utterly destroyed. It is radiographically obliterated, the cartilage is completely gone, the subchondral bone is severely eroding, and the joint is wildly unstable because the ligaments have dissolved.
The factory walls have melted completely. The structure is gone.
At that point, you cannot perform a synovectomy on a joint that is already gone. Stripping out the lining won't give them a functional elbow back because there is no cartilage left to save. For end-stage disease, a destroyed, unstable joint with bone-on-bone arthritis, the only answer is a semi-constrained total elbow arthroplasty.
It makes total logical sense when you frame it causally. You just have to read the clinical stem carefully to see what stage of the disease the patient is at. If they mention preserved joint space, you pick synovectomy. If they mention severe joint destruction and instability, you pick arthroplasty. Let's lock it in with our final rule of the session. If you only keep one thing in the rheumatoid elbow, synovectomy is for the early joint with preserved cartilage, and semi-constrained TEA is for the end-stage destroyed joint. Repeating that one last time in the rheumatoid elbow, synovectomy is for the early joint with preserved cartilage, and semi-constrained TEA is for the end-stage destroyed joint.
Excellent. That covers the entire foundational theory required for this module. We have hit the 3 buckets: overuse, developmental, and reconstructive. And we have respected the 2 nerves stalking our every move.
Which means it is time for the lightning round recap. Fast-paced, rigorous, structured Q&A to consolidate everything we've just spent the last hour dissecting. If you are listening, try to shout out the answer in your car before the expert says it. I will fire the prompt, you fire the exact exam answer. Here we go.
Ready.
Tennis elbow, which specific tendon, and what is the exact microscopic pathology?
The ECRB tendon. And the pathology is angiofibroblastic tendinosis, not an inflammation.
Panner's disease versus OCD of the capitellum, what is the primary discriminator?
Age and prognosis. Panner's is the young child under 10. OCD is the adolescent over 11.
What is the visual tell on an X-ray that distinguishes a congenital radial head dislocation from a traumatic one?
The congenital radial head is dome-shaped and convex because it never formed a mold against the capitellum.
Congenital radial synostosis fixes the forearm in what position, and what is the absolute rule about surgery?
It fixes the forearm in pronation, and attempts at separation surgery always fail due to heterotopic ossification.
Elbow arthroscopy. What are the 2 non-negotiable mechanical safety steps before making a portal?
Distend the joint with fluid to push the capsule away, and flex the elbow to 90 degrees to relax the brachialis.
In elbow arthroscopy, what is the most commonly injured nerve overall?
The ulnar nerve.
Which patient population has the best survivorship for a total elbow arthroplasty?
Patients with rheumatoid arthritis.
What is the lifelong load limit after a total elbow replacement?
Roughly 5 pounds, or 2.5 kilograms.
Name the 2 signature soft tissue complications of a total elbow replacement.
Triceps insufficiency from the surgical approach, and ulnar neuritis.
And finally, rheumatoid elbow treatment. When do you use synovectomy versus an arthroplasty?
Synovectomy is for the early joint with preserved cartilage space. Arthroplasty is for the end-stage destroyed joint.
Brilliant. That is the absolute core of the FRCS elbow pathology and arthroplasty module. We covered the 3 buckets: overuse tendinopathies, developmental lesions, and the reconstructive endgame. And we respected the 2 nerves, shadowing all of it, the pian laterally and the ulnar medially.
Before we sign off, I want to leave you with a final thought to mull over as you finish your drive, something that underscores everything we've talked about today. It is the realization that the elbow's unforgiving biomechanics dictate our entire surgical philosophy.
Right.
Think deeply about that 5-pound load restriction. The fact that a modern marvel of medical engineering like a total elbow replacement limits a patient to lifting no more than a bag of groceries for the rest of their life proves that, unlike a hip or knee replacement, which aims to restore normal athletic function, an elbow replacement is purely a salvage procedure. It is designed merely for basic daily living, getting a fork to your mouth, wiping your face, maintaining dignity. It completely changes the risk calculus of when you, as a surgeon, decide to pull the trigger and operate. You only proceed when the patient's native joint is so utterly destroyed that a permanent, lifelong 5-pound limit is actually an upgrade to their quality of life.
It really puts the gravity of the joint and our limitations as surgeons into sharp perspective. You simply cannot engineer your way out of the elbow's anatomy. That expectation of a perfect, limitless mechanical swap, it really is completely broken here. Next time, we are diving deep into upper limb nerve compressions. We'll be sorting out median, radial, and ulnar entrapments, unpacking the complexities of the ulnar paradox, and teaching you how to confidently tell a peripheral nerve compression from a cervical root issue. Until then, keep your eyes on the road, stay safe out there, and keep revising. You've got this.